afternoon, everyone. Our topic is what should be considered when managing an infected wound.
Most cases of infected wounds are caused by bacteria, originating either from the skin, other parts of the body, or the outside environment. The skin contains its own protective barrier, called normal flora, which is usually harmless if the skin is intact. However, when this protective barrier is disrupted, these normal flora are able to colonize the area, resulting in further tissue damage, delaying wound healing. The most causative bacteria are Staphylococcus aureus, Streptococcus pyogenes, Pseudomonas aeruginosa, and Escherichia coli. Contamination from other parts of the body may also cause wound infection. Bacteria enters the body by three different ways of transmission: direct contact, airborne dispersal, and self-contamination. There are a number of predisposing factors that may contribute to a wound becoming infected. These include presence of an existing chronic infection, long intervals between skin preparation and surgery, some surgical procedures, major tissue loss or trauma, inadequate wound drainage, inappropriate use of wound management material, poor aseptic technique at dressing changes, necrotic tissue, or poorly managed exudate. Wound infections can be broken up into acute and chronic. Acute wounds are things such as surgical or trauma wounds, or even wounds that have arisen from bites or burns. If the infection is localized, the patient may experience symptoms such as the classic signs: new or increasing pain, erythema, local warmth, swelling, or purulent discharge. Fever is also most commonly seen in surgical wounds, typically 5 to 7 days post-surgery. Delayed healing, abscess, or malodor. However, if the infection is spread, the patient would experience all the same symptoms as they would with a local infection, as well as lymphangitis, and inflammation of the lymph nodes in the area of injury, further extension of erythema, crepitus in soft tissues, or wound breakdown. Chronic wounds are defined as wounds which have failed to proceed through an orderly and timely reparative process. Chronic wounds can include bone infections or ulceration due to diabetes, venous, arterial, or traumatic complications. If a chronic wound has developed a localized infection, the patient will experience symptoms such as new, increased, or altered pain, peri-wound edema, delayed healing, easily damaged granulation tissue, change in odor, or induration, which is the hardening of normally soft tissue. If the infection is spread, the patient would experience all the same symptoms as a local infection, as well as crepitus, warmth, induration, or discoloration spreading into the peri-wound area, lymphangitis, erythema extending from the wound edge, or wound breakdown.
Identifying and managing infection in wounds is an important aspect of primary care practice. It is important when considering treatment what type of infection is present. In order to treat the infection effectively with antibiotics, it is imperative to establish what type of pathogen is present. Most infectious wounds are diagnosed clinically, with lab testing used to provide further information to guide management. Microbial assessment, such as swabbing, can be performed in the management of infected wounds. Information of the pathogen present in the wound is valuable to help determine antimicrobial sensitivities for antibiotics and predicting further responses to treatment. Swabbing a wound that is not infected results in unnecessary identification and analysis of organisms which are colonizing the wound rather than causing infection. In primary care, a swab is the most common method used for sampling an infected wound, although biopsy or aspirates of exudate are the gold standard techniques. It is important when taking a swab sample the wound is cleansed prior to avoid false results. Wounds should be washed with saline and superficially debrided, which should remove any devitalized tissue, excess exudate to reveal the virulent pathogen. Wilson 2010 suggests that when taking a sample for culture, it is advised that the tip of the swab should be placed at the deepest area of infection and rotated gently. Ideally, the patient should not have received recent antibiotic treatment before swabbing a wound, as this can affect the results. However, immediate treatment with empiric antibiotics is usually necessary for patients with acute wounds where the risk of infection and complications is increased. Physical, social, emotional, and psychological factors can play a major role in the management of infected wounds. A significant negative relationship has been found between psychosocial problems and healing process. Emotional and psychological factors can affect compliance and motivation. Depression, anxiety, and stress are common emotions linked with the chronic wounds. Socioeconomic background can also affect the management of wounds through insufficient money and access to healthcare. In some cases, patients do not have the opportunity to seek medical treatment and advice due to their location and expenses. Physical status of the patient is important when considering if the patient can self-care and clean their wound independently, or do they need assistance. Other compromising physical factors which delay healing may need to be addressed in conjunction with the current treatment in place. It is important when treating wounds that clinicians take a holistic, patient-centered approach in treatment. Detailed medical and social history should be taken into account. Management, ongoing support, and treatment plans should be provided to ensure the most effective treatment method and ultimately improve quality of life.
Antimicrobials are a suitable dressing for managing an infected wound because they have an antiseptic agent incorporated in them. This then inhibits microorganisms by being applied directly to the wound surface. Some advantages include broad spectrum and bactericidal, and rapid onset but sustained act. However, some disadvantages include damage to healthy tissue. Alginates, however, are slightly different to antimicrobials, where they need exudate to function. Studies have shown that some calcium alginate dressings promote hemostasis in bleeding wounds due to the active release of calcium ions that aid the clotting mechanisms. Disadvantages include not suitable for dry wounds, and the fibrous nature of most alginates can cause an inflammatory reaction as the dressing stimulates a foreign body response. Other appropriate dressings include foams and hydrofiber dressings. Although some wound infections will heal with no antimicrobial therapy, many, in particular immunocompromised hosts, will progress and evolve in deeper tissues and potentially cause systemic infection. Compared with systemic antibiotic therapy, topical application has many potential advantages as well as some disadvantages, as outlined in Table 3 on the slide. To overcome these known deficits, clinicians and industry have defined the ideal potential topical agent for treating chronic wounds, as described in Table 4 on the slide. Some of these agents include properly targeted antimicrobial spectrum for the particular type of infected wound and rapid bactericidal activity. The data makes it difficult to assess the efficacy of topical antimicrobials for chronic wounds. Most studies are suboptimal and have varying designs that are not easily comparable. There are some anecdotal reports and case series involving humans that provide some information. However, clinical trials are necessary to test for efficacy. Unfortunately, many of the published trials do not define the types of patients and wounds, select inappropriate control groups, or have inadequate sample sizes. Therefore, comparison of the study outcomes is difficult. Wound care should always begin with ensuring adequate debridement, removal of any foreign bodies, and pressure offloading from either padding or orthotic therapy. Proper dressings, and then assessing for any arterial or venous insufficiency. Topical antimicrobial therapy, although not currently advisable for most clinical uninfected chronic wounds, does have a role in specific circumstances. Neely et al. 2009 believes its use for burn wounds, in which blood vessels to the skin are often destroyed, will help prevent both sepsis and treat infection. Topical treatments may also prove helpful with the increasing problem of multi-drug resistant organisms that are untreatable with most systemic agents. Another application is to aid the removal of biofilms, which have been implicated in persistent infections. Delayed wound healing becomes inevitable once a wound becomes infected. Therefore, treatment needs to be tailored to see a reduction of infection, so wound healing can resume. Short and long-term goals will need to be established and communicated to the patient, so all parties are aware of expectations and possible outcomes. The patient must also be informed about the difficulty of managing infections conservatively, and results rely greatly on patient compliance to treatment plan.
Other treatment options include antibiotics and surgical interventions. These should be considered when the infection has worsened or become severe and chronic in nature. The following classes of antibiotics are used widely for soft tissue and skin infections and have all been shown to have no difference with respect to the infection outcome and rate of amputations. Each class of drug has a different mode of action and specifically targets certain organisms. So cephalosporin, which is indicated for staph and strep infections, and in people who have mild to moderate penicillin allergies. Fluoroquinolones are indicated for Pseudomonas infections as well as bone and joint infections. Broad-spectrum penicillins plus beta-lactamase inhibitors are indicated for aerobic and anaerobic infections. Carbapenems are indicated for moderate to severe foot infections but are not active against Pseudomonas. Nitroimidazoles are indicated for anaerobic bacterial infections. Lipopeptides are indicated for staph infections when other agents are unsuitable, and glycopeptides are indicated for severe infections when there is penicillin resistance. The choice for which antibiotic to use will be based upon the results from the wound culture. There should always be indications for adequate blood flow to the affected area so that antibiotics will reach the infection. In regards to bone infection, there was also no advantage for any particular antibiotic regime or route of administration. The need for surgical intervention should be considered when there is antibiotic resistance, the appropriate regime is not being tolerated by the patient, when there is a presence of renal failure, which means the antibiotic therapy would be ineffective, when there is a presence of peripheral vascular disease in the affected limb, when there is progressive bone destruction, when the degree of bone destruction compromises the mechanics of the foot, when the patient prefers to avoid lengthy antibiotic regimes, when there is a positive bone to probe test, and when there has been previous amputation in the infected limb. The aim for surgery is to avoid further complications that might arise from an infected wound. In summary, there are many factors and considerations that need to be taken into account when a wound becomes infected. Being able to address these will assist in managing the wound and to achieve an optimal result for the patient.